Thanks very much. So thanks for having me to the organizers. You know, I speak quite a bit about arrhythmias and congenital heart disease at general cardiology meetings, and it's so common afterwards. I get a ton of questions, more so than any other talk that I give, and it just really reflects the yearning for education. So you guys are doing a fantastic job. There needs to be more of these. There really is just a burgeoning field that's been alluded to, and just a complete dearth of information on a lot of the subjects. So thanks very much. I don't have any disclosures. We're going to go into a couple of things. Although this is a tetralogy of Fallot session, there is really very little information on CRT in tetralogy of Fallot. We'll go carefully over the ICD data and the risk of sudden death, but also just to review a couple of things with the other congenital heart disease patients that you're going to see, and specifically focusing on the adults, looking at risk prediction and outcomes, and then some of the different approaches. I'm sure you all know this, but as the patients get older, you can see the risk of heart failure, regardless of the type of disease they have or syndrome they have, heart failure is more prevalent. And if you look at this data here, whether you're going to use a beta blocker, ACE inhibitor, ARB, in patients with the systemic right ventricle, first of all, there's very little data here. These are very small numbers, but looking at response, there really is no definite response to any of these treatments. So we really don't have good medical therapy as people get into a stage of heart failure, regardless of their type of congenital heart disease. So it's important that you need to start thinking about CRT, ICDs in these patients, even though there's not a lot of data. Looking then at the causes of death, sudden cardiac death, and these are really a collection of all the larger studies looking at this. These are large databases, registries, sudden cardiac death, congestive heart failure, and I don't think it's changed very much over the last 20 to 30 years that this has been looked at. Still, sudden death and heart failure are the two most important late outcomes for these group of patients. So sudden death then really is a huge deal, 30 times higher than those patients with normal hearts or acquired heart disease. But I want to make a distinction here so that you leave realizing that there are two aspects to this. The first is that there is scar-mediated VT. So this is the tetralogy of Fallot, which is really the poster child for this. So you have outflow tract scar, and these are reentrant VTs, and it can be in any repaired ventricular heart disease. So there's a scar there, and it provides a margin, and around that scar or that margin or that boundary, you can get these reentrant ventricular flutters. They're like the atrial flutter that you see, but they are monomorphic VT. That's something that can be treated differently, and this is different from that patient who has a bad systemic right ventricle that's failing. This is like the dilated cardiomyopathy. Doesn't need to be scar there. Whereas this tetralogy patient can have a perfectly normal right ventricle or normal left ventricle. They can have the scar and a nidus and the substrate for VT, and also can be at risk for sudden death. So there are two different camps here, and we're going to discuss them separately. So starting off with just a little bit of background on the right ventricle. It's a completely different chamber. You can see here, compared to the left ventricle, it's a thin walled structure, which is really just like an ellipse. And even its squeeze is different. It's not like a left ventricle. It's almost like a peristaltic motion that right ventricle squeezes. So when the right ventricle, which was never designed to pump to the systemic circulation, starts to fail, it's a big deal. The other thing, though, as you can see here, looking at the left ventricular septum, or the septum between the two, a lot of the squeeze from the right ventricle is reliant on the left ventricle. So it's bad when that right ventricle is going down, and it's really a big deal if the left ventricle is going down, because that's supporting it. It's really a platform for a lot of the outflow velocity and squeeze for the right ventricle. You can see exactly that in these muscle bundles that have been very beautifully dissected. This is a very thin-walled structure. And so the question that our lab is trying to look at, and a lot of other groups around the world, that right ventricle, is it more arrhythmogenic? Is it less arrhythmogenic? Can we extrapolate from patients with acquired heart disease, where we have a lot of good data? We've looked at thousands and tens of thousands of patients who have non-ischemic cardiomyopathies or ischemic cardiomyopathies, left ventricular ejection fraction below 35%. It's almost a sure bet they're going to need a defibrillator, and it's part of the guidelines. But we don't know if the same holds true for the right ventricle. Then also, what about the tetralogy patient? What about the Eisenmenger patient, where you've got that very hypertrophied right ventricle? Is that more arrhythmogenic? And we really don't know. The other thing, which was alluded to earlier by Michael, there is this inadequate blood supply. There's really one coronary artery that's supplying that. So very important in the adult patient where they develop coronary disease, and it may be just there is a big circ supplying a lot of that area, or they develop a right ventricular infarct. They don't have a lot of collateral blood supply. So then before going on to the tetralogy group, which is the scar-related VT, this is some data which we've submitted and, in fact, resubmitted. So congenitally corrected transposition, and this is 131 patients from our center. So if they had a right ventricular ejection fraction less than 35%, the incidence of sudden death or appropriate ICD discharge, all the bad arrhythmogenic issues, were much higher in that group compared to if the RVEF was more than 35%. So maybe it's true, but very early data, very small series, just illustrating the need for more collaborative work to clarify this in the failing systemic right ventricle. So germane to this lecture topic, then tetralogy of Fallot, as you all know, a lot of discrete scars in the heart from the VSD, from the outflow tract, from the pulmonary valve itself, and this really can be any kind of ventricular syndrome where there is repair, where there are scars there. Alluded to already, but a long list of predictors for sudden death, ventricular tachycardia, and tetralogy of Fallot. And I'm not going to go through all of these, because how much prediction value does each one of these have when you're sitting on the one side of the table from your patient who's asking, what kind of risk do I have? And we still really don't know. But out of that big group, there really are these four that seem to stand out, that are reproducible through all of them, and these would be the ones that I would certainly look for. The QRS duration, the longer that it's taking electricity to get through the heart, sort of the sicker the muscle, and the more likely you're going to be to set up these reentrant ventricular tachycardias around the scars. So that really is an important one. It's been shown frequently now that if you have a reentrant mechanism for your VT, you should be able to induce that at an EP study. And so if you're in doubt, it's a very good tool to have in your back pocket, or to send to your electrophysiologist and have them test that patient. Documented non-sustained VT, a no-brainer, and then this left ventricular dysfunction. If the left ventricle is supporting so much of that right ventricle, just be aware of that. So important to follow these patients carefully from a heart rhythm perspective. So just showing for some of you that aren't involved in electrophysiology, this was just taken from a case and then made into this animation. A common approach and a common type of VT, the ventricular tachycardia is going around this outflow tract patch on the anterior surface of the right ventricle. It's using this isthmus between the pulmonary valve and the outflow tract, and just ablating through this area, transecting that isthmus, can render that certainly render that particular arrhythmia, and can render patients free of VT. So in speaking about ICDs and tetralogy of Fallot, can we avoid putting in an ICD in certain patients? And that is the case for some of these patients where we can prove that that VT is gone, and it's not the patient with a failing right ventricle. This is a patient with a healthy right ventricle, healthy left ventricle, scar-related VT, and we can prove it's gone, and we can prove that isthmus is blocked. So this is data from our group looking at just depicting a very good outcome from that type of ablation. This is all comers, not just tetralogy of Fallot. This mirrors the work from Boston, and also the same kind of stuff has been shown by the Amsterdam group. So if you have that kind of patient, you may be able to avoid a defibrillator. The other consideration here before putting in a defibrillator, and they're going for pulmonary valve replacement, this is data from our group, and there is also some very good data from Toronto. Cryoablation does not seem to be pro-arrhythmic. So the patient has to go for a pulmonary valve replacement. Lying down, cryo lesions, freezing certain areas which are probably going to be arrhythmogenic for that patient, does not seem to be pro-arrhythmic. Because with catheters we can check, is that a proper line of block? Is that isthmus gone? Is it going to cause trouble in the future? We can prove with pacing it's not going to. Even though the surgeons can't prove that, this is not an arrhythmogenic kind of procedure. And if we look at outcomes, these patients seem to do better. And if we had bigger numbers, more collaborative studies, I'm sure this would be sort of standard of practice and something that you should probably discuss with your surgeons. So this was the original depiction from Gatzoulis of sudden death and tetralogy of Fallot, and you can see looking further along at 30, 35 years, you can see the incidence of sudden death just becoming more and more prominent. Just some emerging data that we've just submitted for Ebstein's. We used to think that Ebstein's was sort of protected somehow from sudden death, even though they've got this big, bad RV. Their average age of sudden cardiac death from our study of almost 1,000 patients of Ebstein's, it looks very similar to tetralogy of Fallot. That being said, we're being sent more sick Ebstein's who are needing surgery, and it's perhaps a much more biased sample. But this is freedom from sudden death, looking very similar to the tetralogy of Fallot group. So looking at the sudden death, the causes of sudden death following all comers with congenital heart disease. You can see here sudden death almost always is going to be arrhythmic. It may not always be ventricular tachycardia, complete heart block, sinus arrest. As you know from all the scars in the heart are not uncommon. But if you're going to take that decision or recommend that an ICD get put into that particular patient, then you have to be aware of this kind of data. It really is striking, and it's very different from the acquired heart disease group. So these are all the studies summarized over the last couple of decades. Appropriate shocks from the device, about a third of these patients are going to get appropriate shocks from the device, much higher than a non-ischemic cardiomyopathy. But even more alarming, in a young group of patients, about a quarter of them are going to get shocks for the wrong reasons. And that's a very big psychological deal for the patients. Since this data was collected, though, we really are programming devices completely differently. I would guess if this had to be done now with the different kinds of programming where we avoid shocks, because not all shocks are life-saving. Some of those episodes of VT will terminate on their own. This may be down in the single digits, but it's still a real deal. But just making sure that you think about that first column. Let me go back there. So think of a patient who has ventricular tachycardia, and you think, well, you don't want this patient to die, so they're going to get a defibrillator. They have non-sustained VT, or even they come into the emergency department with VT. You can see the high rate of appropriate shocks in this group because defibrillators don't do anything for VT. So if you're going to put in a device, the patient's still got VT. The patient's still going to get shocks from the VT. So you need to do something to treat that ventricular tachycardia. And so that's going to be almost certainly ablation or an antiarrhythmic. You can't just put in a defibrillator and think that the patient's not going to get shocked, because no one did anything about the VT. You're preventing sudden death with the defibrillators. So just showing here the difference between the acquired cardiomyopathy. These are from very, very large trials, much higher incidence in tetralogy of Fallot of appropriate and inappropriate shocks. It really is a very arrhythmogenic milieu. And then if you are going to put in a defibrillator, should it be a transvenous device or a sub-Q device? Probably the subject of an entire talk on its own. I'm happy to discuss it afterwards. But in a young patient, I think there is benefit to avoiding the leads, both from an infective endocarditis point of view and also to keep the patency in the vessels. So Anita was involved in this with the ARC group. They looked at the experience, probably 25 or 30 patients, looks that it's very much equivalent. It works well, can be done in adults with congenital heart disease. We looked at about 100 patients who are eligible for sub-Q ICDs. These are all adult congenital patients with all kinds of backgrounds or syndromes, dextrocardia, mesocardia, and found that if the patient was failing the screen, because this this subcutaneous device is sort of looking at the heart like an ECG is, and because of the different vector, they may not always pass standard screening, but you can get the same defibrillation efficacy by having that lead on the other side of the sternum. You can see it's tunneled not to the standard position, but right onto the other side of the sternum, that if they're failing the standard screening, you can move that screening to the right side and you can improve the failure rate. So adult congenital heart disease, about 20% of those patients are going to fail that screening test, and so they'll be ineligible for that device. But think about just moving that lead to the other side. So I'm going to just summarize the ICD data there. Really, there is very little data for the group as a whole. There are small studies. That scar-related VT, you can definitely address that with ablation. And the poor left ventricle, watch out for that in your patient if the right ventricle is bad too. And sub-Q ICDs, I'm using them as much as I can in the young patient who doesn't need pacing. So moving into CRT for the last few minutes. All the CRT trials in the world in acquired heart disease, normal hearts, are really looking at left ventricular dysfunction, left bundle branch block, right bundle branch block we don't have very good data for. And in this failing systemic right ventricle, what do we do? It's just a different beast altogether. And then as a whole, congenital heart disease, there's so many different things with the anatomy, with the way the electricity conducts through the heart, and we really don't have a lot of data. So let's just frame this discussion then with an anecdote. This is a patient of mine from who I've been following for the last decade, 35-year-old with congenitally corrected transposition. You can see his background here of ligation of a PDA and some PA banding because of a VSD. The VSD was then closed, the band was released, he received a pacemaker when he was 2. And then 1998, systemic AV valve replacement with a mechanical valve. Incredible exercise capacity by his report, no symptoms at all, benign Holters, no VT, non-sustained VT, just a few PVCs, on warfarin, DIG, enalapril, and aspirin. This is his VO2. Also instructive here, I'm sure you find this quite a lot in your practice. He says he's doing fine, but if you look at his predicted how he does on the treadmill, even though his peak VO2 is really not too poor, it's really not where it should be. And his echo images I'll show you in a minute, but systemic ventricular dysfunction, and this has been consistent over the last decade and a half. So here you can see his image is really dilated systemic ventricle and function significantly down and extending down towards the apex. So I don't think we're set up for audience response, so I'll just go through this as a rhetorical question. There isn't really a perfect answer here. So what to do with this guy? He's now 39, congenitally corrected, bad systemic ventricle, but it feels great. So transvenous CRT, transvenous ICD. Does he need to go to the operating room and get some epicardial leads put on and maybe an ICD coil? Or can you just do that with the CRT device via the transvenous route? So I was, and I have been, trying to encourage this guy for years to get a CRT-D device. And I didn't show you the dates on that echo, but that echo was 2005 when I was a fellow, and I saw him just about a month ago, and he still has no device. He hasn't died suddenly, and he still feels great, and his heart looks exactly the same. And so it really is a very different group of patients that we're dealing with. So if you look at this, at the guidelines for acquired heart disease, CRT is reasonable now, even if there's an NYHA class 1 and 2 heart failure. So minimally symptomatic or not symptomatic. QRS duration of 150, that gives you the opportunity to resynchronize that heart. At that stage, when this update came out, this was the statement: there remains insufficient data to make specific recommendations about CRT in patients with congenital heart disease. Subsequently, most of you have probably seen this statement, this consensus statement as to what we can or should do in adults with congenital heart disease. But to draw your attention to this, so level of evidence B and C, and that's really what is going to drive all of this group of recommendations. Evidence B would be a single trial, which is randomized, or non-randomized trial. Otherwise, an opinion of experts, case study, or standard of care. And so I don't want to go through the guidelines, but if you can see from there, level of evidence C, C, B, B, C, we don't have very good data. Essentially, and this gets to the tetralogy of Fallot, if they've got a systemic left ventricle, it's very, very similar to acquired heart disease. There's no real difference. If it's failing and the QRS is wide, you can consider that particular patient with the systemic left ventricle for CRT. If you're looking at patients with the systemic right ventricle or single ventricle, really all roads end with CRT. We don't have any good medical therapy for a lot of these patients, and even though the level of evidence is C, it doesn't seem to be a lot of downside to at least considering CRT in these patients. And this is the only class 3. So this is don't do this. So don't do it if you think that if the QRS is narrow. And the other is if you don't think the patient is going to survive, then it's probably not worth subjecting them to that procedure. But even for that one, level of evidence is C. And often, if you look at some of those case reports, patient they thought was going to die was on the transplant list, got CRT, and the patient did wonderfully. So none of it is really out of bounds. So we'll just spend a couple minutes to run through quickly the data on CRT in this group. So some very nice studies from the Bordeaux group, looking at here the atrial switch patients, and you can see here without pacing and with pacing, improvements in the systemic RV, both as far as the EF and efficiency is concerned. Also functionally improving peak VO2 and exercise capacity. And then also the same group showing that in patients with a systemic ventricle or single ventricle, improvements both hemodynamically in this group of patients. And this mirrors the large trials for CRT throughout the other forms of congenital heart disease. These are the 3 major multi-center studies that have been done. Just to draw your attention to a couple of things, even though the EF was low in all of them, and these are generally younger patients, most of the patients in here had a systemic left ventricle, so probably like the tetralogy of Fallot patient. The single ventricles and the systemic RVs really have been underrepresented, and we don't have good data on them. There does seem to be about a 60 to 70% improvement in NYHA class. And we don't really have good data on survival. The studies haven't been out very far. We know for sure that there is probably an improvement across a range of anatomies. But to summarize that, then really small groups, they're heterogeneous, short follow-up, and we don't have mortality data. Just making you guys aware that even your patients with congenitally corrected transposition, A lot of them have a coronary sinus in exactly the same position, even though it's a systemic RV. And they also have these Thebesian veins, which drain that systemic RV, providing quite a lot of opportunity to get in these left ventricular, well, it would be a right ventricular lead there, the coronary sinus leads. This is data that we've just submitted. Overall, reasonable improvement in CCTGA with resynchronization. So I'm going to stop here with a couple of summary points. How do we identify those responders? It's hard even in normal hearts or acquired heart disease. It's going to be even more difficult because of this population where everything is so different from patient to patient. And the patients with systemic right ventricles and left ventricles, is it going to improve both of those groups of patients? We really don't know. We really need more multi-centered studies. And what about doing this earlier, before the right ventricle gets worse or the systemic left ventricle gets worse? We don't know. Where to put the position of the lead, all of that needs to be worked out. So I'll stop there, and thank you very much for your attention.